Welcome everyone. Let's dive right into this clinical explainer. Today we're going to unpack the deceptive reality of acetaminophen, or as it's commercially known globally, paracetamol. As you can see on screen in this close-up of a standard capsule, we're dealing with one of the most widely used, highly accessible over-the-counter medications in the world. But beneath that everyday familiarity lies a really strict clinical threshold that every single practitioner needs to understand inside and out.
Here is our roadmap for today's session. We'll quickly cover an overview of the drug, step through its exact mechanism of action, break down clinical uses and dosing, and then dive deep into toxicity, the NAPQ pathway, overdose stages, the antidote protocol, and finally, crucial patient counseling points.
Starting with Section 1, Paracetamol, an overview, and the deceptive reality of a common analgesic.
Now, to understand why this drug demands our respect, consider this classic clinical presentation. A 22-year-old female arrives at the emergency room 18 hours after an intentional overdose of about 20 tablets. The catch? She is completely asymptomatic. As you look at the points on screen, you'll see her vitals and liver function tests are entirely normal at this stage. But make no mistake, despite her stable appearance, her liver is already dying. This perfectly illustrates the paradox of paracetamol. It's incredibly safe and well tolerated at therapeutic doses, even on an empty stomach, but it is silently fatal in a massive overdose. You have to look far deeper than initial vital signs.
Let's move to Section 2, Mechanism of Action, specifically focusing on inhibiting the COX pathway.
Now let's look at the pharmacology. As you can see in the mechanism mapped out on screen, let's trace exactly what happens inside the cell. When tissue trauma occurs, damaged cells release phospholipase enzymes, right? These enzymes break down the cell membrane's phospholipids into arachidonic acid. From there, your cyclooxygenase, or COX enzymes, convert that acid into prostaglandins, the messengers that signal pain and trigger fever. But here's where paracetamol steps in. It systematically slows down this COX activity, but mostly isolated to the central nervous system, the brain and spinal cord. By dropping those prostaglandin levels centrally, it prompts the hypothalamus to just reset the body's internal thermostat, so body temperature lowers and pain is reduced. Though it's important to note, we aren't actually treating the underlying cause of the inflammation.
So, clinically speaking, how fast does this happen? When taken orally, you're looking at a rapid onset of 30 to 60 minutes for noticeable headache relief. It can even start reducing a fever in as little as 6 minutes, with the therapeutic effects lasting up to 6 hours as the drug circulates.
Which brings us to Section 3, Clinical Uses and Dosing, comparing therapeutic versus toxic thresholds. Pay close attention to the table on your screen. Memorizing these exact dosing thresholds is absolutely vital because the margin of safety here is razor thin. An adult's maximum daily dose is 4 grams per day. That's roughly 8 standard 500 milligram pills. Exceeding that tips you right out of the therapeutic zone. A single toxic dose sits at just over 7.5 grams, or greater than 150 milligrams per kilogram. For your standard adult patient, true clinical toxicity starts around 10 grams, or about 20 pills. But the human body is remarkably resilient. If you intervene promptly with the right antidote, we've seen recorded cases of patients surviving massive ingestions, ranging anywhere from 50 to an incredible 104 grams.
However, you cannot apply those thresholds blindly. Look at the susceptible populations listed here. Not everyone has the same safety margin. Patients struggling with alcoholism or those who are malnourished have severely depleted glutathione reserves. Patients with pre-existing cirrhosis already have compromised liver function. And if your patient is taking enzyme-inducing medications like phenytoin or carbamazepine, their P450 metabolic pathway is basically in overdrive. Finally, the elderly and very young children naturally have altered liver metabolism. These specific groups require much stricter supervision and highly modified prescribing.
Let's transition to Section 4. Toxicity and the NAPQI pathway, or the CYP2E1 metabolic shift. To really grasp the toxicity, we need to understand how the liver actually processes this drug. As you can see in this breakdown on screen, under normal conditions, the vast majority of paracetamol is safely metabolized. 55% is handled by glucuronide conjugation, and another 30% goes through sulfate conjugation. It's this remaining, seemingly tiny, 15% that is shuttled through the P450 enzyme pathway. And right there, that 15%, is where the clinical danger lies.
Because that pathway produces something called NAPQ. This is a highly toxic intermediate metabolite. Now, normally, your liver has no problem handling this. It perfectly neutralizes NAPQ using its natural stores of an antioxidant called glutathione. But During a massive overdose, those primary conjugation pathways we just talked about get completely saturated. So, where does the excess drug go? It reroutes entirely to this pathway, causing a massive, dangerous spike in this toxic compound.
Let's walk through this catastrophic system collapse step by step. The primary pathways are overwhelmed. The excess paracetamol forces its way into the CYP2E21 pathway. Toxic NAPQ spikes. The liver scrambles to neutralize it, rapidly burning through its limited glutathione stores. Once those stores are completely gone, unbound NAPQ accumulates, binding directly to liver macromolecules, causing severe hepatic necrosis. And it doesn't stop there. As the liver tissue dies, it basically stops filtering blood. The blood backs up into the hepatic portal vein, down into the inferior vena cava, putting immense, potentially fatal pressure right onto the right ventricle of the heart, eventually leading to systemic organ failure.
This brings us to Section 5, Overdose Stages and the Antidote, the race against hepatic failure.
Once a toxic dose is ingested, you are literally in a race against time. Notice the clinical timeline on screen. From 0 to 24 hours, you're in the preclinical stage. This is what we saw with our 22-year-old case study. Normal labs, asymptomatic, maybe some mild nausea. It's incredibly deceptive. By 24 to 72 hours, we hit the hepatic injury stage. You'll start seeing right upper quadrant pain and rapidly rising AST and ALT enzymes. At 72 to 96 hours, you're in full hepatic failure, jaundice, encephalopathy, high INR. And finally, days 4 to 14 mark the recovery or death stage. That initial 24-hour window is your critical opportunity to act.
So, how do we treat this? First, you need a precise patient history. When exactly did they take it? How much? Was it extended release? Next, you absolutely must wait to check serum paracetamol levels until strictly after the 4-hour mark. Testing before that will just give you inaccurate absorption data. Then, you plot those levels on the Rumack-Matthew Nomogram. If their level crosses that critical treatment line, you initiate the antidote immediately. And a quick clinical tip: if the patient actually presents within 1 to 2 hours of taking the pills, give them 1 gram per kilogram of activated charcoal to try and stop the gastrointestinal absorption early on.
Now, if that nomogram dictates treatment, we immediately turn to N-Acetylcysteine, or NEC. This brilliant antidote literally saves lives by directly resupplying the liver with the glutathione it desperately needs. As you can see on screen, this is typically a 21-hour, 3-bag IV protocol. Bag 1 is your loading dose, 150 milligrams per kilogram delivered over 1 hour. Bag 2 slows down to 50 milligrams per kilogram over the next 4 hours, and Bag 3 delivers 100 milligrams per kilogram over 16 hours. If you can get this protocol started within 8 hours of ingestion, you're looking at a near 100% success rate in preventing severe liver damage.
Finally, Section 6, Counseling and Drug Interactions, Preventing Toxicity on the Front Lines.
Because the truth is, the most effective medical intervention happens at the pharmacy counter before the overdose ever occurs. When you are counseling patients, you have to clearly warn them about the dangers of combining this drug with excessive alcohol. Always cross-check their chart for those enzyme-inducing medications we discussed. Advise extreme caution with over-the-counter cold and flu meds. They are notorious for containing hidden paracetamol, which causes accidental double dosing all the time. Emphasize that strict 4 grams per day limit. And importantly, let them know that toxicity is a slow process. If an accident happens, there is almost always time to seek emergency help before permanent damage sets in.
I want to leave you with this stark clinical reality, perfectly summarized by the quote on screen. Paracetamol toxicity does not scream for life, it whispers until it's too late. Never, ever rely solely on early symptoms. Because as we saw with the young woman in the ER, the damage is completely silent. And by the time the liver finally screams in pain, your window to save it might already be closed.
So, knowing exactly how easily that CYP2E1 pathway can be overwhelmed, and knowing just how deceptive that preclinical stage truly is, how is this going to change your clinical approach? The next time you recommend or prescribe this seemingly harmless painkiller, I want you to keep this in mind. Consider it carefully the next time you step into the clinic or pharmacy and handle this incredibly common yet deceptively dangerous medication.